Pharma. So today the topic of discussion will be Clostridium difficile, or nowadays the taxonomy has changed. They have told this change the name to Clostridioides difficile. Okay, so we'll start. Okay, so this Clostridioides difficile, it causes antibiotic associated diarrhea. So what is antibiotic associated diarrhea? It is unexplained new onset stools, more than 3 stools with a past history of antibiotic use within the preceding 12 weeks, or any in the past 3 months. If somebody has taken an antibiotic, it can cause antibiotic associated diarrhea. So if you ask which all antibiotics cause antibiotic diarrhea, it will be highest risk will be for clindamycin, fluoroquinolone and cephalosporin, and that is cephalosporin above the second generation, that is even your ceftriaxone, cefotaxime, ceftazidime, all this can cause diarrhea. There is a moderate risk with penicillin, macrolides, carbapenems, metronidazole, vancomycin, and the risk is quite low with aminoglycoside, tetracycline and cotrimoxazole and rifampicin. So this is how you get antibiotic associated diarrhea, and it is not actually synonymous with Clostridioides difficile, because there is some other bacteria also that is causing antibiotic associated diarrhea, which involves Clostridium perfringens, Klebsiella oxytoca, occasionally Staph aureus, Salmonella, Candida. All these are occasionally associated with antibiotic associated diarrhea. Okay, but our topic of discussion today is C. difficile. So what is peculiar about Clostridium difficile? It is the ability to form spores. Okay, this will exist in the form of spores. So bacteria can be treated, but treating spores is really difficult. Treating or eradicating spores from any place is quite difficult. So as I have enumerated, spores are resistant to heat, resistant to drying, resistant to pressure, resistant to disinfectant, resistant to almost all the antibiotics. So even if you know what antibiotics to treat with, spores are resistant to that if they exist just as a spore form, and these survive very well in the hospital environment up to months. So these are some problems with Clostridium difficile spores. So how do you define an So how do you define C. difficile? C. difficile is the presence of diarrhea defined as passage of 3 or more unformed stools in 24 hours, along with a stool test positive for the presence of toxigenic C. difficile, or if there are colonoscopic findings of suggestive of pseudomembranous colitis. So what is of particular importance is that they are unformed stools, and most likely, almost often, the stools are watery stools. Okay, if you get blood in stools, it is mostly not C. difficile unless it is going to very severe complication. Okay, so blood in stools is usually not a picture of C. difficile. It is watery stools. Okay, clear watery stools, if it is there in your ICU patient, you suspect C. difficile, and for telling that, it has to be the, what is mentioned here is the toxigenic C. difficile. So for a proper diagnosis, you need the C. diff toxin to be positive. Okay, we will come to the details. So before that, there is something called as Clostridium difficile colonization. So what is colonization? It is just the presence of bacteria without causing an infection. The bacteria is there. So most often in our lab test, this is detected by what is called as C. diff GDH antigen. If the GDH antigen is positive, it just shows that C. difficile is there. If it is causing the infection, more often than not, the toxin is positive. Okay, so 4 to 15% of healthy adults and quite a lot number of infants have the C. difficile colonization, and 21% of hospitalized adults do have it, and in long-term care facilities the numbers even increase. But the problem is that even if somebody is colonized, they have a very high risk of developing infection at some point of time. The risk is, as I have mentioned, 6-fold. There is a 6-time risk that this patient can develop C. difficile during their hospital stay. So only thing is, that is why you need not routinely send swabs for all the patient. Unless the patient is not having diarrhea, there is no need to test the stool, because if stool is tested, mostly they will you will find C. difficile, and no need to unnecessarily treat those patients. Okay. So what is the pathophysiology? The antibiotic use affects the gut microbiome, and this pathogenic flora will start increasing. And once the gut flora is altered, it will create a conduit for colonization of C. difficile, which can later produce this toxin. So there are two toxins mainly, toxin A and toxin B. So toxin A is an enterotoxin and toxin B is a cytotoxin. No need to, from your level, it is not needed to go in details of this toxin. But in the year 2005, another toxin was discovered, which is the new strain NAP-B1027. It is called as a binary toxin that again causes infective C. difficile. So what is peculiar about C. difficile? As I mentioned, there are other bacteria also that can cause the infection. So 25% of all the antibiotic associated diarrhea are associated with C. diff, and 50 to 75% of antibiotic associated colitis is associated with C. diff, and almost always the condition named pseudomembranous colitis is associated with Clostridium difficile. And the Indian prevalence is 7 to 26% of this bacteria. And if you go to the split up, there have been various studies from our country with incidence varying from 16%, 6.3%, 15%. On an average, it is around 10 to 15%. And that is the incidence of C. diff in Indian ICUs. So coming to the risk factors, age more than older people have a higher predilection for getting C. diff. Hospitalization, excessive antibiotic use. If somebody has inflammatory bowel diseases, immunodeficient patient, recent gastrointestinal surgeries, prior history of C. difficile, and use of pantoprazole or ranitidine. So this also is a risk factor. So anytime, whenever any patient comes to our ward or ICU, every patient, it is a free medicine. You give pantoprazole. Okay. So this actually increases the risk of C. difficile. So that is why unnecessarily pantoprazole is not to be given. Okay. And how do you recognize C. diff? As I mentioned, it is almost always watery diarrhea. It is not a bloody diarrhea. It is always watery diarrhea. There will be fever. There can be fever. There can be abdominal pain, tenesmus and abdominal pain. Leukocytosis, the counts keep increasing in severe diseases, and some of them do develop hypoalbuminemia and elevated serum creatinine. And when the disease progresses, the colon gets involved, leading to pseudomembrane formation. Okay. So there are some severity scores. So one score that can be followed is this Atlas score. It says that if the age is higher, patient is having fever, high leukocyte count, low albumin and raised creatinine, you always send for the test for Clostridium difficile if the patient is having diarrhea, because the probability increases as the score also increases. So if you go by the incidence of clinical features, 50% of them do have fever, followed by abdominal pain around 40%, and the rest of the factors that I mentioned, leukocytosis 27%, raised urea, raised creatinine. So these are the factors in C. difficile. And now we will go in for what are the severity, how do you classify the severity. So severe C. diff diarrhea is when the patient's creatinine is more than 1.5 and the total leukocyte count is more than 15,000. Okay. So these are there are only two criteria for a severe C. diff. It is important because these kind of severe, the treatment, there are some changes with respect to the treatment, whether it is severe or whether it is recurrent, whether it is fulminant. If the patient is in shock or ileus, you can call it as fulminant C. diff infection. Okay, so there are quite a lot of complications like megacolon, very high WBC counts, hypotension, high serum lactate, altered mental status and hypoalbuminemia. So these are complications of C. diff. So basically till now what the take home messages will be, it will be a watery diarrhea. You always see for the count, see for the creatinine. So if counts more than 15,000, creatinine more than 1.5, it is a severe C. diff. and you should see for these complications that are enumerated. If the patient is in shock, whether there is any perforation, whether the counts are too high. So these things has to be seen. So just a word on, actually these complications have been defined in different ways by different authorities, because some of them do say, some authorities do say if the temperature is more than 38.5, that is again a sign of severity. This has been told by American College of Gastroenterology. If American ACG usually emphasize more on the albumin levels. If the albumin levels are low, they consider it as a severe C. diff. And IDSA, this whatever I have mentioned is the Infectious Disease Society of America classification, which says only creatinine and leukocytosis as a criteria for severity. Okay. So now with these clinical features, we will go into how do you treat C. diff. So for treating C. difficile, you need to test them. Okay. So before testing, you need to see what symptoms you should test. So the crux is that in patient with watery stool, more than 3 stools in 24 hours, you do testing. And routine testing of children actually is not advised, because children, as I mentioned, the risk of colonization is up to 70%. So those less than 2 years, better not test for this unless it is maybe a post-transplant setting you can test for. And repeat testing of stool sample is not advised, because once the test is negative, if you have high suspicion, it is okay, but to see whether the patient has cured of C. diff, that testing is not needed. Once you diagnose, that is it. Okay. And for this, how do you send the stool? A single fresh stool sample is to be given, and it should be, if you are transporting to the lab, it is ideal if you transport it in an anaerobic medium, which is most often not followed, but even a sterile container is okay for that purpose most of the time. And the lab actually should assay the toxin within 2 hours, and if you are planning to store it, the stool can be stored for 2 days at 4 degrees at normal refrigeration. So these are the conditions where you should test for C. diff. So we have quite a lot of tests that is available. So it can be GDH, which has a good negative predictive value. So the advantage is that if you send the stool and if the GDH is negative, it is very unlikely to be a case of C. difficile. GDH is negative. So, but the problem is that it can be present in infection as well as in colonization. So it won't differentiate. So for testing whether the patient is actually having infection, you test for toxin A and toxin B, and if the toxins are present, it is C. diff. Okay. So nowadays, other than toxin, there is this PCR test also, that is a nucleic acid amplification test. So it is not just to detect the bacteria, you have these genes that are being tested, TCD-A and TCD-B, which codes for the toxin. So if a PCR test is testing for nucleic acid amplification, is testing for these genes, that again is an indication of C. difficile. Okay. So there are culture tests, these are done, the last two are done only in research settings. So the take home point from this is there are 3 types of tests. One is the GDH, one is a nucleic acid amplification, and the third one is a toxin testing. That these are the tests that we do routinely. So coming to the how you diagnose, the diagnostic algorithm will be, so this is quite important. Stool sample, first you can test for GDH. First you test for GDH, see whether it is GDH positive or negative. So if GDH is negative, the test is C. diff negative. You label the patient as C. diff negative. So if the GDH is positive, okay. If the GDH is positive, you send in for the toxin assays, and if the toxin is positive, it is presumed to be C. diff infection. If the toxin is negative, then if available, you can send for this PCR, because even though the sensitivity of the tests are quite good, the problem is occasionally the toxin tests do come negative. So what happens is, if the toxin is negative, the recommendation is that if available, you can send for a PCR for the toxin gene. It is not just to detect the bacteria. So this is a confusion, because nowadays you have these stool biofire panels that is available. Okay. So if you send for the stool biofire panel, they will test a large list of bacteria and viruses like rotavirus, norovirus, rotavirus, adenovirus. But that will test only whether C. diff is present or not. So that is not the NAT, that nucleic acid amplification, that we are intending. If testing, you will have to send for the C. diff PCR for this toxin based one, TCD A and B gene. So if they are positive, again you can treat them as C. diff. Okay. So this is how you should test for C. difficile. So start with GDH. GDH positive, go for toxin. Toxin negative, go for PCR. Okay. So this is the algorithm. But nowadays some changes. Just before the talk also, I was discussing with Jacob sir. So occasionally we have condition where the patient is having persistent diarrhea, and the persistent diarrhea is there, but C. diff GDH is positive and toxin is negative. Okay. Suppose you do a biofire and you are not having any other alternative explanation for your diarrhea and this clear watery stool, then again these patients also are candidates for treatment. Okay. Okay. So it is not like every case you need not treat. It is like, so the theory is one way and treatment is another way. You don't have any other explanation for diarrhea, maybe because many time you are not sending for the specific PCR for C. diff. Okay. But actual guideline goes like this. So if you are not going in for the PCR, the problem is that you might have to end up treating the patient as C. diff. Okay. But clearly it should be watery diarrhea. So there are different nowadays the panels have there are quite a lot of panels. So in the TrueNet machine or Gene Expert machine, there is possibility for testing for expert panel. So it is a closed system, and they some of them do test for this binary toxin also. So these tests are available nowadays. So the kits are also available for, so the TrueNet machine nowadays can test a lot of bacteria. It can test Klebsiella, it can test Staph aureus, it can test for C. diff. So if all these are good tests. So if it is available, you can test this. So with this, we will move in forward to the treatment. So fortunately or rather unfortunately, actually C. diff is the thing for which a maximum number of guidelines have come in the past 15 years. So actually why so much guidelines have come? Maybe because there is a lot of market push for this so-called drug fidaxomicin. Okay. So every other year, some more 2013 ACG, American College of Gastroenterology guideline, 2018 IDSA, 2021 IDS ACG, 2021 IDSA. So IDSA is actually our association, Infectious Disease Society of America. Usually for meningitis and UTI, they put forward some guideline in, I would say that 15 to 20 years, one guideline comes. C. diff, it has already come. It is said and done. There are guidelines. Okay. So what as residents or critical care fellows, you have to study the guidelines and you will have to write these answers in the exam. So the problem is that again we don't have this thing guideline, and all the guidelines say that fidaxomicin is the drug of choice. So always if you write an answer, you write fidaxomicin first. Due to non-availability, we are going in for vancomycin. So okay, we will come to the treatment, but there is this another thing also which is not available in our country, Besilotoxumab. Okay. So treatment option, at least for practical purposes, our first drug is always oral vancomycin, which mostly is available in the form of a tablet vancomycin. But the problem is that the dose is 250 mg that we get. Okay. Fidaxomicin has a lot of advantage actually. It is not a bad drug. Always why the market push is there, all the trials have favored fidaxomicin because the risk of recurrence is really less. It is a prolonged post-antibiotic effect. That is why you end the treatment at 10 days and the effect will last quite longer. That's why the risks of recurrence are really low with fidaxomicin. But this advantage is not there for vancomycin. Metronidazole has gone down the lane because the recurrence and relapse are really high for metronidazole. So nowadays it is not a favored drug. And there is some evidence, there are some studies with teicoplanin also instead of vancomycin. It is said that the amount of recurrence with teicoplanin is a little lesser in comparison with vancomycin. But we need more studies. Again, as you know, teicoplanin is not an FDA approved thing. It is not there in US. So you won't have a lot of trials with this drug again. So last year this new drug came, ridinilazole I will be discussing. This drug okay for recurrence, it is quite good. And the last resort will be fecal microbiota transplantation. So comparative effectiveness, if you ask me which one is the best, FMT has a really good advantage in terms of cure rate, and in recurrent cases definitely fidaxomicin wins it. Non-recurrent ones, all these drugs can be given. Okay, if one attacks, all these drugs can be given. Ridinilazole, only one recurrence. So these cases it can be given. Fidaxomicin, fecal microbiota transplant, and this drug nitazoxanide also has found its way to treatment. All these are okay. And probiotics nowadays, there previously it was being pushed as a treatment for C. diff, but unfortunately trials have not proven that probiotics are said not to be very effective. That is because everyone's gut flora is varying. That is different. Okay, you give a probiotic, so actually it is not known whether it is something that is helping you, or it is creating a problem. First episode and yeah, first episode. No, in recurrent cases vanco is there. I will come to the treatment, but fidaxomicin is better. Okay, in non-recurrent one, all these have a role. I will split it up. Okay, and FMT, if you are going oral and colonoscopic. Now actually regarding the fecal microbiota transplant also, there are different ways by which nowadays even ready-made capsules are available with fecal microbiota. You can just take those capsules which has fecal microbiota, and that also is coming up in a big way. So there are different compositions for that. So okay. So now coming to the treatment, how do you treat C. diff? So the first episode, if it is a non-fulminant one, the choice is the agent of choice. The actual guideline I have written here is the initial episode. This is what all the guidelines says, fidaxomicin. Okay, fidaxomicin 200 mg twice daily for 10 days. I have written vancomycin here only because this is the thing that is available for us. So you write this, but you treat with this. So that's how it goes. Okay. So fidaxomicin is not available. In refractory non-fulminant CDI, teicoplanin or nitazoxanide has a role. Okay. So vancomycin, the dose that is recommended is 125 mg 6 hourly, 4 times daily by orally, but the capsule that is available is 250 mg. So there is no harm in that. So it is like oral vancomycin does not get absorbed. It will just fully excrete in the gut only. Okay. So it does not increase the risk of nephrotoxicity, and your whatever IV vancomycin you are given, that won't reach the gut also. Okay. So if you are planning to give IV vancomycin, that is not a treatment for C. diff. If patient is having C. diff, even if the patient is taking vancomycin injection for some other reason, some other MRSA or enterococcus, you will have to give this oral preparation also. So it works like that. So that is about the non-fulminant C. diff. So drug of choice is vancomycin, and the dose is 125 mg, or maybe what is available is 250. Adum, it is 4 times daily itself you will have to give. No need to reduce, because it does not have any systemic absorption. So this is one common problem that is being faced. So if the vancomycin capsules are not available, so some hospital does not have this vancomycin capsule. So it is said that there are 2 ways by which you can do. You can just use the IV preparation. You should dilute that. How to dilute I have mentioned here. So the dose is 125 mg 6 hourly, and in Ilias it is 500 mg 6 hourly. This guidelines I have taken from the NHS. So what they say is to reconstitute the vancomycin 500 mg vial in 10 ml of water for injection, and then you will have to dilute the required volume, and you can dilute it with sterile water, and you can ask the patient to swallow. So again, if the patient is having a Riles tube, again you can go for this. This mostly happens in Ilias if the patient is having enteral feeding tube. So in Ilias, mostly the dose will be 500 mg 6 hourly. Again, but this is not a recommended route actually. This route is not licensed, but practically again you can reconstitute the 500 mg vial with 10 ml of water and to make a concentration of 50 mg per ml, and you can give it like that. Okay, you can dilute it even with 20 to 30 ml of sterile water, and after flushing the NG tube you can just administer. Okay, but the vials for vancomycin are for single use only. So even if you are giving this 125 mg, you will have to discard the vial after that. So that is how you give this vancomycin vial. Okay, so vancomycin via tube. So this actually a lot of hospitals are not stocking these vancomycin capsule. So this is one easy way by which it can be tackled. Now coming to how do you treat recurrent C. diff. The first recurrence again it goes by these things, fidaxomicin and vancomycin. So fidaxomicin, in these cases this recurrent C. diff is the way by which you can go in, are the cases where you can go in for something called as pulse therapy. Okay, how do you see for the pulse therapy? Either you can give the normal dose, because fidaxomicin is okay, it is, as I told, it is a good post antibiotic effect, or 200 mg BD you can give for 5 days, and then you can give it OD for every alternate day for the next 20 days. If you are giving vancomycin, it is like you give the normal dose 4 times daily for 10 to 14 days. After that it is 2 times daily for the next 7 days, once daily for the next 7 days, and then every 2 to 3 days, because vancomycin does not have post antibiotic effect. So the first recurrence, again the treatment drugs remain same, but recurrence always use this term pulse regime. That is how you treat recurrence. And second recurrence again same, fidaxomicin and vancomycin. And if there is multiple recurrence, again there is an option that you can give vancomycin, and maybe you can give this drug rifaximin also along with that. Rifaximin also can be given. And multiple recurrence fecal microbiota transplant can be tried. So if it is a fulminant C. diff, oral vancomycin, fulminant C. diff is the place where you can give combination therapy. So vancomycin plus metronidazole. Nowadays, whatever I have shown, metronidazole is out of most guideline. Metronidazole is always lower down the list. That's why I have not mentioned it. So, but in fulminant C. diff, you can use it in combination. Nowadays, tigecycline also is having a good role in treating C. diff, in fulminant C. diff. So you can give vancomycin oral along with metronidazole, and along with oral or rectal vancomycin. Again, rectal vancomycin also the preparation remains same, whatever I have mentioned. Okay, in Ilias case you can give the rectal vancomycin. So this combination has a lesser mortality in fulminant C. diff. And refractory patient, if nothing is working out and you are not going in for fecal transplantation, then the bowel resection is the last way. So surgical opinion need to be taken. Just a word on FMT. FMT is the administration of fecal matter from a donor into the intestinal tract of recipient in order to change the recipient's microbial composition. So it is not like a bone marrow transplantation or a solid organ transplant. This is a simple procedure. You need not do a lot of tests before fecal microbiota transplantation. Okay, because there is not much risk of rejection. Even if it rejects, it will just go out. That's all. So okay, so I am not going into the detailed process, but nowadays a lot of gastroenterologists are collecting stool from other people. But the thing is, actually we are also can't make sure that which gut flora is better. Okay, we are just taking the gut flora of some other patient and putting inside our patient. But whether this gut flora is always helpful, we don't know. Most of the time it works. It is like that. It is like, it is not like some patient might have more firmicutes, some might have more bacteroides. We don't know which patient who has a better flora. So mostly it works. So that's how about C. diff. Just a word about patients in C. diff in your ward being detected. So just follow. C. diff is something where the patient has to be isolated, because the risk of spread is quite high, and the problem is the spores will remain in the environment. So always you will have to remove it is difficult to eliminate the spores. So isolate the patient first, and always use gloves and gowns. C. diff is somewhere you should use gowns also, because the spores might come and you might transmit it to the next patient, and contact precaution has to be followed. And the contact precaution has to be followed for, you need not do a repeat testing, but 48 hours after the diarrhea has settled, that is the time when you should stop isolation for C. diff cases. And hand hygiene is most important, but the thing is, hand hygiene in C. diff is to be with soap and water. It is not our alcohol based hand rub, because that won't eliminate the spores. So always C. diff is, in fact, only the diarrhea is the only place where we mandatorily recommend soap and water hygiene. In all the other cases now ABHR has replaced that. So outbreaks, hand hygiene with soap and water, it always wins hands down. It is significantly more effective in the trials also. So I think I have this much only. So just revising the guideline, initial CDI episode, this is how you should write for exams. Start with fidaxomicin as a preferred, and vancomycin will be written as alternate. And if nothing is available, only you try metronidazole. And first recurrence, again fidaxomicin. In recurrence, the only other term that you should use is this pulse regime. Drugs remain same. Okay. And there is an adjunctive bacillotocimab also. Second recurrence, again same. FMT comes here in the second recurrence and recurrences after that. And fulminant C. diff, vancomycin via mouth or NG tube. In ileus, you can add rectal instillation, and IV metronidazole also may be tried. Thank you.
Thank you, sir, for the kind introduction. So I'll be talking about TBA and SAH. Sir has given me like big topics to be put in half an hour, so I'll try to do justice as much as possible. So about the brain, we have a rigid skull which has got three components, that is the brain, the CSF and the blood. So if any of these components come in excess, the intracranial pressure is going to come high. So whatever we try to do in, especially in both these conditions, is try to bring down the intracranial pressure. So if the brain is swelling up, you try to dehydrate it. If the blood is pooling, you try to reduce the cerebral blood flow or the cerebral whatever the blood volume that is coming. And if the CSF is going high, you try to take it out by EVD or Dumbar drain. That is like the crux of whatever we try to do in traumatic brain injury and in aneurysmal SAH. So subarachnoid hemorrhage, it can be traumatic and aneurysmal. So what I am talking is aneurysmal subarachnoid hemorrhage. The incidence is between 3 to 20 people, about 100,000 people, and it mostly affects younger age group around 40 to 60 years. Women are more seen, and it has kind of a geographical predisposition to some areas of Japan and Finland, and there is also family inheritance. So coming to there is two parts of the pathophysiology. There is the early brain injury part and the derailed cerebral ischemia. The early brain injury occurs within the time of the rupture of the aneurysm till 3 days. That is when the aneurysm ruptures, there is going to be blood in the CSF. So that is going to raise the cerebral blood flow, increase the ICP, and is going to reduce the cerebral blood flow and also can cause hydrocephalus. So this all these changes, because of the blood that is sitting outside the brain, is going to cause a global cerebral ischemia. And suddenly when the blood is coming over to that space, the sympathetic activity is increased, a sympathetic drive is increased, and this is going to affect all other organs in the body. So the heart is going to have the stress reaction, it's going to have stress cardiomyopathy, neurogenic stunt myocardium. 80% of the patients will have ECG changes or arrhythmias, and myocardial stunting can happen. And all of the inflammation, necrosis and apoptosis will occur, and the blood-brain barrier is disrupted. So after the 3 days, the patient is going into the delayed cerebral ischemia phase, and here what happens is the blood is lying over the brain, so it's going to irritate the brain, and that is going to cause all the sequelae that comes with the SAH. So those is because of the endothelial dysfunction, the procoagulant activity, and the cortical spreading depolarization. Though this ultimately lead to cerebral vasospasm, blood is sitting there, irritate the vessels, vessels will start closing up. So that leads to cerebral vasospasm, can cause microthrombus, so patient will have small strokes. Then it leads lot of loss of autoregulation and lead to hemodynamic responses. So how do these patients present? They will have typically the worst headache of their life. They can have central headaches, that is, in the preceding 2 weeks, they will have small incidences of headaches, can have sudden loss of consciousness. Why that occurs? Sudden rupture of the aneurysm, the intracranial pressure will go high and they will lose consciousness. According to the specific location of the aneurysm, then can have typical symptoms like when pica aneurysm that is sitting directly next to the third nerve. So they can have, the pupil can be blown and they can be comatose. There are different grades. I'll come to this. There are clinical grades as well as the grades are according to the scans. So how do we diagnose them? They can initially come. The first modality of choice is CT. First, for 24 to 48 hours, CT has the highest sensitivity. It can detect, CT angio can detect aneurysms up to 5 mm of size. Below than that, CT does not have a good predictive value. If the CT is negative but high, you are suspecting that it is high likely aneurysm, you can do an LP. Xanthogram can be seen, that also has very good sensitivity. After 48 hours, you have to either take up the patient for MRI angio or take the patient to cath lab, do DSA. How do we stabilize these patients? Airway, very important. Secure the airway. If the GCS is less than 8, oxygenation, maintain it, and avoid hyperoxia, and also carbon dioxide, very important, maintain it, 35 to 45 mmHg. And the most important part of the aneurysm, once it has bled in the first 72 hours, very high chance that it will bleed again. If the patient bleeds again, very high chance of mortality. So your main goal in the initial phase is to prevent the rebleed. How do we prevent the rebleed? Control the blood pressure. That's the only thing majorly you can do. Control the blood pressure, target, let's keep less than 160, and the MAP should be less than 110. Any kind of coagulopathy, patient is on any medications, correct that. And there's an ultra trial which shows that ultra early administration of tranexamic acid can reduce the incidence of rebleed, but it does not increase the outcome of the patients. And when the patient has raised ICP, you monitor the patients, assess the pupils, give proper analgesia. You'll have bad headaches, so give them analgesia, give them antiemetics. And the patient has seizures, treated, fever, treated. And EICP, give hypertonic saline or mannitol. If any medical management fails, go ahead and put an EVD. And all other parts, maintain the HP more than 8, maintain normal bulimia, correct any electrolytes, and monitor the ECG. And nimodipine, that is the one thing that has been shown to improve the outcome, give the nimodipine. If you're suspecting SAH aneurysm, put the patient on nimodipine, 40 mg 6th hourly. And this is the grades. There is clinical grades, that is Hunt and Hess and the WFNS. The Hunt and Hess is grades from 1 to 5 depending upon the consciousness of the patient. Modified pressure based on CT. It is either depending upon the thickness, whether the aneurysm, the SAH thickness is less than 1 mm, more than 1 mm, and whether any IVH is present or not. And WFNS is based upon the GCS and whether they have any focal deficits or not. Less than 14 GCS, less than 13 GCS, focal deficit doesn't matter. Patient's GCS is low, anyway they're going to have the poor outcome. So one of the important concept I want to tell is about transmural pressure. Transmural pressure is that is the mean arterial pressure minus the intracranial pressure. So whenever the patient has an aneurysm, this is the basilar top aneurysm that is sitting there, and the patient has SAH. So what is holding on to aneurysm is that there is a blood pressure that is pushing the aneurysm from inside, and the bleeding that has happened has increased the intracranial pressure. So a transmural pressure gradient, that is anything that will cause the aneurysm to rupture. So if you increase the MAP, the aneurysm is going to rupture because the transmural pressure is going to be high. And another thing is intracranial pressure. We are trying to manually control the intracranial pressure, but if you reduce the intracranial pressure very drastically, that is you put an EVD, sudden gush out of CSF, aneurysm is going to rebleed. If you give mannitol, the nurse has opened it, aneurysm is, the ICP is going to be drastically become, like they have to give it over 15 to 20 minutes. Over 5 minutes, mannitol is in hypertonic salinism. ICP is going to go down very rapidly. Transmural pressure is going to be high. Patient can rebleed again. So the duration of giving treatment is also important in that. So early, your thing you have to worry about is rebleeding. So control the blood pressure, and the only thing that can prevent rebleeding is go and secure the aneurysm as early as possible. So either you do it by endovascular coiling or surgical clipping, and you have to control the blood pressure till the aneurysm is secured. And extreme blood pressure fluctuations or changes in the transmural pressure across the aneurysm wall can cause rebleeding. So not only the brain, other systems are also affected. I'm not going to go into detail. There's cardiovascular effects, pulmonary effects, Electrolyte imbalances, like they can have SIADH, DI, hypokalemia, hypocalcemia. Patient will go into hyperglycemia. Cardiovascular, most of the patients will have ECG changes, neurogenic stunt myocardium, cardiomyopathies, and they're prone for thromboembolism. So what all you have to do? You have to monitor the patient, you have to do regular clinical assessments, monitor the ICP, take up the patient for angiographies like CT, CT angio, DSA or MR angio, to do bedside transcranial Doppler to assess the velocity of the MCA to see if the patient is going into vasospasm, do an EEG, intermittent or a continuous EEG, to know one thing is whether the patient is having any non-convulsive status, or to know if they is having any cortical spreading depolarizations, because that can also be picked up in an EEG, and brain oxygen monitoring by PbTO2 and cerebral blood flow monitoring. So how do we prevent DCI? DCI occurs after 3 days. So there is a window in which you can prevent that. That is by maintaining normal volemia, maintaining normal sodium levels, and maintaining normal glycemia and normothermia. Other supporting measures like DVT prophylaxis, anemia correction, then prevent the hospital acquired infections, glucose control, and electrolyte arrangement. Then control the ICP, that is adequately give analgesia, prove sedation. If the patient is on ventilator, do not give high pressures, control the intra-abdominal pressure, keep the head in a neutral position, and maintain normal volemia, and whatever fever and seizure, treat it. Then cardiopulmonary support, as well as to treat the DCI, that is hemodynamic augmentation, endovascular therapy, there is no improvement. So this is in summary of all the guidelines, that is AHA has recently given guidelines, I think 2023. So the level 1 of evidence is oral nimodipine, should be given to all patients because it's the only thing that has been found to improve the outcome. It will not reduce the vasospasm, but it will improve the outcome. Other than nimodipine, no other calcium antagonist has been found to be effective. Then other thing of class 1 evidence is secure the aneurysm early, clipping or coiling depending upon the location of the aneurysm and the feasibility. And other thing is blood pressure should be strictly controlled. They do not give a target, but what is preferred is to keep less than 160. Other class 1 evidence is patients should be always referred to a high volume center, low volume centers. That means centers that do cases less than 35 aneurysms, cases less than a year, don't treat them, always refer, because the patient outcome has been found to be significantly high. The patient is treated by cerebrovascular surgeons, endovascular specialists, and multidisciplinary neurointensive care units. Other thing is maintain normal blood volume and euvolemia, and patient who develops DCI, you have to induce hypertension. And other class 1 evidence is to do CSF diversion, that is either by EVD or lumbar drain, depending whether the patient has hydrocephalus or not. Other recommendation is class 2 is to keep the BP less than 160. Other thing is to do serial TCDs, not one TCD, serial TCDs, every 4th hourly or every 6th hourly, to do TCDs to see if the cerebral blood flows velocities are going up, to know if they are going into vasospasm. And normothermia to treat anemia, and short-term tranexamic acid. These are all level 2. So the complications, hydrocephalus. So now people are more trials are coming towards lumbar drain. So there is an early drain trial that came in 2023 that said prophylactic lumbar drain insertion has been found to increase the neurological outcome at 6 months. In 2024, the lacrosse trial came, that is lumbar drain versus EVD. They found that patients with lumbar drain had lower DCI rates, shorter ICU and ventilator days, and shorter daily duration with lumbar drains. And so it has been shown in few trials to improve the outcome, but still it's not so much coming to the practice of putting lumbar drain early. Coming to seizures, most seizures occur within 24 hours of hemorrhage, and when the patient throws a seizure, you have to keep a high suspicion that the aneurysm has rebled. And it is mostly seen with younger patients, patients who are having MC aneurysms, and also when they have big hematomas in the parenchyma. So EV. That is for hydrocephalus. Whenever you detect hydrocephalus, is that as early as possible, go ahead and put EVD. Either you can. So either you can put the EVD as early as possible, or when you take up the patient for definitive, like you're doing a clipping, you put an EVD along with clipping. So as early as possible, secure an EVD. The only thing in EVD is that don't open it too much so that all the CSF comes out fast. You have to have a controlled drainage. That it can be in aneurysm, it can be communicating hydrocephalus or non-communicating hydrocephalus. Lumbar drain it down. So immediately you will not know if it is communicating or not communicating. But usually it is a communicating hydrocephalus that usually happens. So that is why a lumbar drain is coming more forward. But there's a lot of complications with lumbar drainage. Infection chances high. You have to competent. The staff has to be competent in managing. So all that is there. And plus, some people are very hesitant to put it because the ICP is already high in the initial stages. So everybody is worried that patient might fall if you put a lumbar drain. So early, that all these trials they have tried to put lumbar drain early before itself the definitive procedure. That's why lumbar drain is more coming into all these trials are giving importance. Some people, one trial they've done both EVD and lumbar drain. So try to put whichever is better that way. Train it from up and down. So what the purpose is, you take out as much as blood from the arachnoid space and reduce the incidence of vasospasm, and see. That's the whole concept behind that. Seizures, a routine anti-epileptic prophylaxis is not advised, probably due to association with cognitive impairment and increased complications, and is basically reserved for high-risk individuals. Non-convulsive status epileptics can occur in 20% of patients. Continuous EEG is recommended, especially for poor grade or unexplained depressed consciousness. Like your CT is not looking so bad, but your patient is not waking up. So high suspicion of NCAC should be there. Vasospasm, this shows TCD, which show you have to see the mean flow velocities. TCD has a level 2A, class 2A, level B evidence for vasospasm surveillance. So it has a good sensitivity around 90% and specificity of around 71%. So how do you diagnose it is, you put the probe in, see the MCF flow velocities. If it is more than the mean flow velocities is more than 120, there is a high chance. If it is less than 120, high negative predictive value, and more than 180, very high chance that the patient is having vasospasm. The Lindergaard radio is which you use because you have to see whether the extracranial ICA velocities and the intracranial ICA velocities has to be seen. So the ratio shows if it's less than 3, it's just hyperemia. 3 to 6 of ratio, mild vasospasm, more than 6, severe vasospasm. So serial TCDs has to be done, and if you're feeling that the patient is having vasospasm with the TCD, take up the patient for either CT angio or directly go a DSA so that you can intervene in the meantime also. Coming to delayed cerebral ischemia, it's characterized by any neurological deterioration, that is focal deficit or decline in the GCS more than 2 points, and the deficit is lasting more than 1 hour, and you can't find any other cause why the patient is having the decreased response. So it is distinct. Vasospasm is another NIT, DCA is another NIT, and the triple H therapy that was recommended before is outdated. Only induced hypertension is the only one that has any evidence now, and this induced hypertension is after securing the aneurysm. So you have to first make sure that the aneurysm is secured before increasing the BPM. And nimodipine has to be given. Another coming up is milrinone. There's a Montreal protocol for using milrinone. The milrispasm trial recently came. They found it is efficacious, but the thing is, when you start milrinone, patient starts having hypotension. So there was poor tolerance in about 29% of patients. Other is clazosentan. Clazosentan also has not been found to increase the outcome. Then other is do a CT perfusion and as well as do a CT angio, and then you can predict whether the patient needs angioplasty. So the whole DCA management is centered around inducing the hypertension and nimodipine. So other therapies, adjuvants like milrinone and advanced monitoring, you can all use that, but evidence is more towards both these. Transfusion, 2 trials recently came, the TRAIN trial and the Sahara trial. They are all slightly in favor towards liberal strategy, that is HB towards 9. It's not found to increase the outcome as such, but slight superiority is seen in both trials. Temperature management, fever should be aggressively treated, and outcome benefit, but aggressive treatment of the fever, protocolized treatment has not been shown to be better than the standard treatment that was shown in the interpret trial. Coming to traumatic brain injury. Traumatic brain injury, whatever I say has come from the BTF 4th edition. So അതെ ഇത് ചോദിക്കാം. You can, if whatever says is that if your CT is inconclusive, go ahead and do LP. That's what, if to do diagnosis. Like if you see xanthochromia, you can do the CSF study, see if RBCs are there. So that's what everybody says, but practically nobody does it. First CT angio, if that's not there, wait, go ahead and do a DSA. That's what is practically done. LP, all studies, textbooks you see LP they do, but practically nobody does it. Because everybody is in the worry that patient will cold. That is why the lumbar drainage is also getting so much of importance. Who will do lumbar drain? Who has the guts to put a lumbar drain in the patient who is ICP is high? Same thing.
Coiling and clipping, is there any difference in the BP chart?
Definitely. Post coiling and clipping, usually keep a higher BP. What guidelines is that you don't have to prophylactically induce hypertension. You don't have to keep an NORAD just because an aneurysm is clipped or coiled. So if you're suspecting, if the patient is having high grade of SAH previously for the procedure itself, so they are suspecting high incidence of vasospasm. So a WFN is 3 or Miller Fisher grade 3 is going to have incidence of vasospasm or DC around 33%, around 40, close to 40%, 38 to 40%. That is like what, up to 1 in 2 of the patients is going to have DCA. So everybody will keep their BP high. That's what the evidence also says. So you don't, unless your SAH grade is very good, then you don't need to increase the BP. But if your suspicion that the patient is going to have vasospasm, patient is going to have DCA is high, induced hypertension is always given. You maintain the euvolemia, usually with pressors. First preference is put on Norepinephrine. In Norepinephrine, you put an infusion, increase the BP. Target is usually 170, 180. 170, 180, still patient is having neurology deficit, increase the BP 200, 220. You keep the BP as much as high as cardiac status is permitting. You keep the BP high as much as possible. So once, if you're keeping the BP high and the patient's deficit is resolving, that means your induced hypertension is working. So that's clinically, you induce the hypertension and you clinically assess the patient. They're improving, you keep the BP and give more BP. That's what is practically done. No. Targets are same. Clipping aneurysm is secured means that you induce hypertension. 160, 180, whatever patient can tolerate, whatever the heart can take. Secured, unsecured, you will never increase the BP. Your target is less than 160. Only thing you have to see from critical care is whether the aneurysm is secured or not. Another important fact for what the question is that if the patient is having multiple aneurysms, like some aneurysm, the ruptured aneurysm, they would have clipped or coiled, but one IC aneurysm is there, one IC aneurysm is there, other aneurysm is not secured, then you will not induce, you will not take your BP to 200, you will keep it around 160, 170, that range, because you don't want the unsecured aneurysm to rupture. That is one condition where you do not induce that much hypertension. IV nimodipine, oral nimodipine, all the trials, whatever gave level 1 evidence is oral nimodipine. But IV nimodipine, recently there's one ongoing trial that is seeing if IV nimodipine is better. But whatever studies has been done comparing both equal outcome, nothing is saying that IV nimodipine is inferior. So oral nimodipine is always preferred unless you're feeling the patient's gastric absorption is not sufficient or your patient can't take orally. In that cases, we'll give IV nimodipine. But every studies, all trials favor towards oral nimodipine, but comparison, IV is not inferior. And IV is not found to be superior also, so oral is fine enough. Only thing is hypotension should not be there. You give nimodipine, patient's BP will go down. So you have to watch about that. If 60 mg, patient's hypotensing too much, you make it to 30 mg. 30 mg 4th hourly you give. Even that is not tolerating, you increase the duration. But nimodipine has to go with somewhere. Or you maintain the blood pressure with norepinephrine and give nimodipine. But nimodipine has to go somewhere. Any more? So coming to traumatic brain injury, by definition, traumatic brain injury is disruption in the normal function of the brain that can be caused by a bump, blow, or jolt to the head or a penetrating head injury. So classified It's based upon the severity. There's different ways to classify based upon the severity. It's basically mild, moderate, and severe. Mild is between 13 to 15, moderate is 9 to 13, and severe is less than 8. And anatomically, you can classify whether it's focal or diffuse, and based on CT, you have the Marshall classification and Rotterdam. The crux of both these classifications is whether to see if the patient's basal cisterns, if there is any, whether the cerebral edema is there, if there is any basal cisterns that is effaced, and if there is any midline shift or if there is any lesion. That are the three things that has to be seen. So this is a Marshall and it's a Rotterdam classification, and there also whether it's a non-evacuated mass lesion or it's an evacuated mass lesion. So depending whether when the midline shift becomes more than 5 mm or the high intensity or mixed density lesion is more than 25 cc, it becomes significant and the grade becomes high. So severe TBI is when the GCS is between 3 to 8. It is a major and challenging problem. So our main aim is to prevent the secondary brain injury. There is a primary brain injury that occurs at the time of the impact. We can't do anything about it. So what we can change is a secondary brain injury. And what happens is what causes secondary brain injury is your hypoxia, hypotension, hypercarbia, hyperglycemia, and hypoglycemia. All those will cause secondary brain injury. And when the patient has secondary brain injury, they have increased mortality. So there can be causes of secondary brain injury that is systemic as well as intracranial. The intracranial causes can be when there is any cerebral edema, hematoma that is sitting there, of any vasospasm, and the systemic can be your uremia, your ammonia going up, or the other causes, hypoglycemia, hyperglycemia, or the other systemic causes. So coming to the lesions, acute EDH. EDH occurs when there is injury to the middle meningeal artery. You have to see that it's an arterial deep, so it will expand very rapidly. So this is how an EDH looks, like a crescent shape. And one good thing about EDH is that you go in, you remove it, the patient outcome will be very good if you evacuate it as early as possible. So what are the indications for surgery? The patient has deteriorated, the hematoma volume is more than 30 and the clot thickness is more than 15 mm. Coming to acute SDH, this is a crescent shaped or moon shaped lesion. The thing with SDH is that it is below the dura and just above the brain. So the amount of damage, the amount of the effect on the brain is high. So high volume of SDH again will take up for surgery. So when do you take up for surgery? When the thickness is more than 10 mm and there is a midline shift more than 5 mm, when the GCS drops more than 2. If these two, like midline shift more than 5 mm and the thickness is more than 10 mm, in spite of whatever the patient's GCS is, they'll be taken up for surgery. Otherwise, if the thickness is less but the patient's GCS is dropped, or the pupil has become dilated, or if you measure the ICP and the ICP is more than 20, those will become indications for surgery. Other lesions, the parenchymal lesions, you can see a bifrontal hemorrhagic contusions. So in these also, if the patient's GCS is low, or if the contusion volume is more than 20, or the midline shift is more than 5 mm, or the cisterns are effaced. Here you can see a little bit of cisterns are visible, but mostly cisterns are effaced. So in these patients will again go for surgery. Other indications for surgery is when they have a depressed cranial fracture. You can see the bone fragments is found in the brain parenchyma. Most probably it can be a contaminated wound, dura is punctured, gross deformity, or if any like this, if the frontal sinus is involved, all those cases patient has to again go for surgery. Posterior fossa mass lesions, less incidence, but if it is there, they will have rapid neurological deterioration because less posterior fossa, less space is there. So anyway, more amount of brainstem and parenchyma is going to be compressed. Another part is diffuse axonal injury. It is present in 40 to 50% of the patients. What happens is that they are having an acceleration deceleration injury. So neurons, the connection between the neurons is affected. So acceleration deceleration, the neurons slip away. So it will not be seen as any mass lesion or anything. Your CT might be normal, patient's GCS will be 8. So that's when you have to suspect that the patient has diffuse axonal injury. The main clinical signs: altered sensorium, global cerebral edema. And surgically you can't do anything about it because you're not seeing any mass lesion or hematoma or anything to evacuate. So there's nothing you can do about it. But the diagnosis is mainly clinical and then with MRI because CT will be usually normal. All you can see is cerebral edema. Airway management: any patient low GCS, go ahead and intubate. Main reasons: they might have facial injuries, bleeding, hypoxia will be there which will lead to secondary brain injury, and they can have a loss of respiratory drive. Many patients will come with a tube, either they'll go to OT and come, or come directly to ICU. They will always have a tube in place, always take the position of the tube. And another thing, these patients, around 4 to 8% of patients will have an associated cervical spine injury. So always and always when you tube them, you have to make sure that the neck is stabilized, the cervical spine is stabilized. And because the spinal cord, there is a high chance that spinal cord injury can occur. So how do you know, or whether when to get an imaging? Like patient who has low GCS, they have sent here. When do you know you have to get a CT C spine or an X-ray C spine? There are two criteria: Nexus and Canadian C spine. So whether the patient is not having any posterior cervical midline tenderness, the patient is not intoxicated, is normal talking, there's no focal neurological deficits, and there is no painful distracting injuries, that they don't have like a femur fracture or a tibia fracture, something that is distracting them from the neck. If nothing like that is there, you don't need to image the patient for a cervical spine. But any of these is there, you go ahead and do imaging. Canadian C spine. So if they have the screening criteria, that's if it's an elderly patient that is more than 65 years, the dangerous mechanism, the patient was a front seat passenger, or if it was a high velocity injury, that is a dangerous mechanism of injury, or if the patient is having any paresthesia in extremities, you go ahead and image. If none of these is there, so if it is like a simple rear end motor collision, or if the patient is sitting in the emergency department, or they don't have any sort of neck pain, and there is no any midline cervical tenderness, if nothing is there, and if nothing is there, then you ask them to rotate the neck 45 degrees to both sides. If they are able to do it, there is no need to image. But if any of this is present, you go ahead and image those patients. So how do you intubate? You do manual inline stabilization. So if you have a CMAC or a video laryngoscope, go ahead with that. But whatever is you are comfortable with managing the airway, that should be your instrument of choice. It should not be like, oh, it's unstable cervical spine, I have to go ahead and intubate with a CMAC or video laryngoscope. No, if you're not comfortable with it, don't do it. Do a manual inline stabilization and tube the patient. Blood pressure targets, your CPP should be around 60 mmHg. The target is between 60 to 70. So in TBA, there's the initial first 72 hours there's a hypoperfusion, and after 72 hours luxury perfusion is there. So your CPP targets is around 60 to 70. So this is what cerebral autoregulation looks like. So when the patient has having preserved autoregulation. So however you increase the BP, the blood vessel is going to constrict and it's going to maintain the blood flow. The cerebral blood flow is not going to increase whenever you increase the BP too much also. So the intracranial pressure is going to be maintained. But brain has sustained an injury, the autoregulation is impaired. You increase the MAP, the cerebral blood flow is going to be increased, and with that the intracranial pressure. So everything becomes proportionate to each other when the autoregulation is impaired. So when the intracranial pressure goes high, your cerebral perfusion pressure comes low. So so your management all depends whether your autoregulation is impaired or your autoregulation is preserved. So BTF 4th edition says to maintain a systolic blood pressure more than 100 mmHg in patients 50 to 69 years old and more than 110 in anybody more than 15 years of age. So only exception of 100 is 50 to 69. And the CPP is between 60 to 70. CPP is MAP minus ACP. So your CPP cerebral perfusion should be between 60 to 70. And you have to do aggressive attempts to increase the BP beyond 70 should not be done, especially with fluids and pressors, because there is a high risk of acute respiratory failure. So what fluids you use? You should use something that is isosmolar or hyperosmolar. Never use something that is hypotonic. And can we use colloids? Basically no. The SAFE trial was there which showed that patients with traumatic brain injury given colloids had a poor outcome. But another pitfall was SAFE trial used 4% albumin instead of the 20% standard albumin that we use. But never use glucose containing solutions, never use hypotonic solutions. That's the base crux of the fluids and traumatic brain injury. How do you resuscitate? Transfusion, crystalloids, possible do a TEC, and give factors according to the TEC. Another thing is BTF, the only level 1 evidence in BTF is that not to give steroids, and the level 2 evidence is bifrontal decompressive splenectomy, about feeding and seizures. Those are the only 2A levels of recommendation. Everything that comes in BTF is 2B and level 3. So about ventilation and oxygenation, you should maintain a PaO2 more than 80 and normocapnia has to be maintained. A brief period of hyperventilation, that between 30 to 35, is recommended when the patient is acutely neurologically deteriorating. So this is only when you feel that the pupil is blown, or when the patient whose GCS was like 13 or something has dropped to like 9, 10, you would have immediately shift the patient to CT, or the patient is tube and from 10 they have deteriorated to like 6 or something. So till you manage, get the patient to CT, bring the patient back, only those times you can use hyperventilation, that very, very brief period. You do not hyperventilate the patient for 24 hours or something like that. That is not recommended, especially acute first 24 hours, never recommended. So no prophylactic hyperventilation, that is especially to a PCO2 less than 25. It is only a temporizing measure to reduce the elevated ICP, and in the first 24 hours after TBI, do not hyperventilate because already the cerebral blood flow is reduced. So your one part of the brain autoregulation might be impaired and other part the autoregulation might be normal. So you're hyperventilating, the cerebral blood flow is going to be reduced. When you take up CT, you'll see infarcts in other parts of the brain. That's because you hyperventilated and all those vessels are closed up. So that is one thing that you should not hyperventilate these patients. And if you're using hyperventilation, you have to use something that is measuring the O2 and CO2 in that brain parenchyma. So either you have to use SGVO2 monitoring or brain tissue oxygenation. If you're not using any of those things, don't hyperventilate your patients. And there is very high incidence of ALI and ARDS, 10 to 30%, and high tidal volume is independent predictor of acute lung injury. And protective ventilation, that is lung protective ventilation, low tidal volume, moderate peak, has been recommended to prevent ventilator-induced lung injury. And whenever the patients are on tube, the suction has to be fast. You have to put 100% FiO2 before you suction, and patient has to be adequately sedated. So you don't want a patient with high ICP with the cerebral edema and they are doing suction and the patient is continuously bucking on the tube. You don't want that. Make sure your patient is adequately sedated before you do suction or any sort of intervention in these patients, because slight amount of them awakening from sedation will increase the ICP and the damage, then you can't reverse the damage. They are prone for ARDS and pneumonia, and they also have, your polytrauma patients will have associated pneumothorax, flail chest, lung contusions. They will have cervical spine injury, so that might need ventilator support. So the goal of mechanical ventilation is to prevent aspiration, to reduce the work of breathing, and to prevent secondary brain injury. Then also tracheostomy in traumatic brain injury patients. Basically, if the patient is not going to improve, you're not able to extubate the patient, most probably in the 5 to 7 days, we'll go ahead and do tracheostomy because they are going to be in that debilitated condition for quite some time. So what we want to try to achieve is decrease the duration of ventilation, decrease their ICU stay, and decrease their ventilator associated lung injuries, and also the requirement for sedation. So we usually, what pre-procedure is, we within first 7 days make a decision. They are not going to improve, not able to extubate, go ahead and do tracheostomy. And you're extubated, they have failed. So it's a failed extubation. So one or more failed weaning trials, tracheostomy again has to be considered. So these are some trials that came for lung protective mechanical ventilation after acute brain injury. The PROLABI trial, they also said that considering the neurological outcome of this patient, doesn't matter whether you give them like lung protective ventilation and the standard ventilation strategies. So there's no particular mortality benefit of the ventilation strategies. And this is the Venti brain study that came. Here also they found that the only thing is high plateau pressure was strongly associated with increased ICU and 6-month mortality, but there was no any clear relationship between the ventilator settings and the long-term neurological outcome. How do you examine the patient's bedside? GCS, pupillary reactivity to light, and most of the 40% of the patients in the first 48 hours they will worsen. So how do you say they are worsening? Your GCS decreases 2 points, and in the GCS, in the E, V and M, your preference is given to the motor component. So if a motor score becomes M6 to M4 or M5 becomes M3, that is given more precedence than the patient who was talking became V3 to V1. So whether you tube or not tube, the more preference of the GCS motor score take precedence over other parts of the GCS. And it is usually when they have worsening, it is because of raised ICP, and it can be associated when they worsen, usually associated with poor outcome. So coming to herniation, they have a mass lesion. So I said skull is rigid, you have something that is sitting there other than the 3 components, or one of those components is increasing. So here you have an EDH. So this is pressing upon the brain on this side, that's on the right side. So what will happen is that the brain has parts, that is the dural folds. So it is very tightly packed. There is no space for it to go. What it tries to do is that this mass is going to push the brain from this side to the other side. So the falx is sitting over there. The only place it can go is below the falx. That causes the cephalocene herniation. And here there is a dural fluid, that is the tent is there. So there is a supracerebellar, supratentorial and infratentorial. So the tent is sitting right over there. So anything causing a mass effect from up to down can cause a central herniation. Or here in this case, the mass is sitting on the right side. So it will put pressure, and uncus is the most medial part of the temporal lobe. So that can push the temporal lobe, the middle part of the temporal lobe, into the infratentorial compartment, and that causes the uncal herniation. Nothing else is there, pushing the whole brain down, the cerebellar tonsils will herniate, and that causes the tonsillar herniation. That is, the tonsils will go through the foramen magnum. So how do we manage raised ICP? Suspecting, admit to ICU, tube the patient, and you neurologically assess the patient. Simple thing to do, elevate the head of the bend 30 to 45 degrees. The main concept is that the venous pooling will not occur. You drain the venous part of the blood volume, again ICP will come down. Give good analgesia. If the patient is on ventilator, sedate and prevent agitation, and prevent ventilator asynchrony, and prevent fever. Needed, you can put an arc line, put a central line, do ETCO2 monitoring. You have to maintain your MAP, maintain your HB, maintain your cerebral perfusion pressure. Then other things, or inspect whatever I said before, and then on tier 1 you can give mannitol or hypertonic saline. If hydrocephalus is there, put an EVD. If the parenchyma probe is there, you can monitor the ICP, and if the patient is having seizure, high risk of seizures, give anti-seizure medication. You can consider continuous EEG monitoring. Tier 2, there is mild hypocapnia, that is 30 to 35, never go below that, and neuromuscular paralysis can be given if you feel that your sedation is not working. And tier 3 is thiopentone coma, and then comes the secondary decompressive craniectomy and mild hypothermia. So coming to what the decompressive craniectomy, whatever you are tried medically, that is, you have tried to put an EVD, given hypertonic saline, mannitol, head and elevation, analgesia, sedation, nothing is working, then you take the patient up for decompressive craniectomy. So how do they do is, there's a large flap, even if there's a mass lesion, they'll try to do a large frontotemporal decompressive craniectomy. They do is remove the skull, put the dura back, suture it up. That's all they do. They try to create space. That's all what we are trying to achieve with decompressive craniectomy. And the bifrontal decompressive craniectomy is not recommended. That is from here to here. But the frontal part they try to put, that is not recommended. And only frontotemporoparietal decompressive craniectomy is recommended. So what is found is that doing that is found to increase the outcome of the patient. We can reduce the ICP, you can reduce the number of days the patient is in ICU. So purposes to reduce the ICP by removing a part of the skull. There are two types of decompressive craniectomy. Primary is when you have an EDH or an SDH, they take up the patient, remove the mass along with the board. Secondary decompressive craniectomy is when none of your medical therapies has worked. Your bedside critical care management hasn't worked, so they have to go ahead and remove the board. So what the guideline says is that secondary decompressive craniectomy is only reserved for late refractory ICP, that is to reduce the mortality and to improve the outcome. And large FTP decompressive craniectomy is preferred. The trials which supported is the DECRA trial, and which found that the ICP, the ICU stay and the ventilator days were decreased, but the 6 months functional outcome was not good. The rescue ICP trial also did with decompressive craniectomy patients, and they found that the patient is able to live, they will survive, but how will they survive? The more of the patients are in a vegetative state. So, the decision to take the patient up for decompression is what we are trying to achieve. Is the patient going to be in a vegetative state for after 6 months also? They are alive, but they are in a vegetative state. That is what you have to weigh when you recommend a patient for decompression. So there's no point of living like that in a vegetative state. That is going to increase everything. Social and economic factors are going to be affected. So that is what the rescue ICP and DECRA told. Patients will live, but the outcome will be very poor. So analgesia, sedation, and anesthetics provide good analgesia to limitate the increase in ICP. to reduce the oxygen consumption and also reduce the carbon dioxide production. And then you have to, when you give sedatives, you have to also make sure that there is no cardiac depression, there is no hypotension. If it is there, you have to manage that. And what BTF says is that routine use of neuromuscular blockade to paralyze the patients in TBI is not recommended. Neuromuscular blockade can be used to reduce the ICP and considered as a second line therapy to intracranial hypertension. So all patients, you don't need to paralyze. You just sedate them. This is the sedatives, everybody knows that. So about the use of anesthetics, that is barbiturates. So barbiturates induce burst suppression measured by EEG as prophylaxis against the development of intracranial hypertension is not recommended. So what it means is that if you feel the patient's ICP is high, but it's not something you can manage with analgesia and sedation, you should not go ahead and give a thiopentone coma to that patient. It's not recommended to prophylactically give thiopentone coma. Only when all other measures doesn't work, then you give thiopentone coma. So only when refractory elevated ICP is there, you go ahead and do high barbiturate therapy. And to do that, the patient has to be hemodynamically stable before and during therapy. So most probably when we do thiopentone coma, patient will have hypotension, they will have cardiac depression. So all those has to be managed because your cerebral perfusion has to be managed when you do thiopentone induced coma. High dose barbiturate coma only and only when all other measures doesn't work, and just before or you take up the patient for decompression as a last resort of what you can do in the ICU. Propofol is usually recommended, but again, high dose propofol also has its adverse effects. Then coming to hyperosmolar agents, salt versus sugar, anything you can use mannitol or you can use hypertonic saline. BTF does not differentiate between two. You can use any of those two agents, whatever you are comfortable with. And whatever the patient, if the patient is having renal failure, do not use mannitol. So the main mechanism by which it acts is that because you dehydrate the brain, you reduce the blood viscosity and improve the microcirculation. That's how they all work. And the dose is 1 gram per kg of mannitol. You should give it over 15 to 20 minutes. Even if you're giving hypertonic saline boluses, give it over 15 to 20 minutes. And mannitol is contraindicated when there is renal failure and there is risk of pulmonary edema and heart failure. And mannitol continuous infusion, there's no advantage over giving it as boluses. Mostly it is given as boluses only. And hypertonic saline, a lot of studies in the last 10 years have come saying superiority over hypertonic saline over mannitol, but BTF does not give any specific recommendation. So your target is 150 of sodium, upper limit of 155 of sodium. So BTF says hyperosmolar therapy may lower ICP, insufficient evidence on clinical outcome or to support any specific agent, especially in patients with severe injury. And CSF drainage, so you put EVD which is zeroed at the level of the midbrain and with continuous drainage of CSF to lower the ICP more effectively than intermittent usage. And CSF drainage with initial GCS of 6 within the first 12 hours of injury can be considered. Considering other facts, coagulopathy and DVT prophylaxis, anemia, HB usually target is around 9, and any coagulation abnormality corrected with blood products, and venous thrombosis has to be prevented by usually sequential compression devices or low dose heparin or unfractionated heparin. But what BTF says is that may be used with mechanical prophylaxis, but if you use low molecular or unfractionated heparin, there can be incidence of hematoma expansion. Steroids, Crash said only level 1 evidence that steroids should not be used for improving outcome or reducing the ICP. High dose methylprednisolone was associated with increased mortality and now it is contraindicated. On nutrition, patients should be fed early, at least by day 5 and at most by 7th day, and transgastric gingival feeding is recommended to reduce the incidence of VAP. Seizures divided into early and late seizures. Anything occurring before 7 days is early post-traumatic seizures, after 7 days is late seizures. And prophylactic use of phenytoin or valproate is not recommended. Phenytoin, that is what BTF says is you don't need to prophylactically use them. And phenytoin is recommended to reduce the incidence of early post-traumatic seizures. And levetiracetam, although in practice mostly everybody is using levetiracetam, BTF says there is insufficient evidence to say you use levetiracetam or use phenytoin. You can use either of those agents. Hyperglycemia, hyper and hypoglycemia both have to be prevented. Aggressive control of the blood sugars less than 180 should be avoided because Tight glycemic control also has been found to have poor outcome. Fluids, already said that, use isotonic solutions or hypertonic, no hypertonic solutions or colloids. And hyponatremia, commonly seen, DI, mannitol can cause osmotic diuresis, so all those has to be managed. Hyponatremia is very deleterious because it can cause brain edema and increase in the ICP. Infection prophylaxis. So patients who have this invasive ICP monitoring have found to have high infection around 27%, especially EVDs. Proper care has to be done, and when CSF sampling is done, has to be sterile. And the incidence of VAP is also higher in TBI patients than non-TBI. BTF says about this, early tracheostomy will reduce the mechanical ventilation days, but there is no evidence that it will reduce the mortality. And you should not use povidone ID in oral care to reduce the VAP. And level 3 evidence is there for antimicrobial impregnated catheters and may be used to prevent catheter-related infections. ICP monitoring, whether or not used, there's a lot of trials for that, whether it is beneficial or not. What BTF says is that ICP should be monitored in severe TBI and an abnormal CT scan, or if the patient is having severe TBI, that GCS is less than 8 but your CT scan is good, so normal. So in those patients, if the age is more than 40, if the patient is having posturing or if the BP is low, you go ahead and do ICP monitoring. How do we do it? Is put a EVD, that is intraventricular catheter, or you put a subarachnoid bolt or epidural bolt or intraparum canal. So any of these can be used for ICP monitoring. ICP target is 22, anything more than 22 you treat it. And you have to not only use ICP alone, standalone, you have to use your clinical examination, your ICP values as well as your CT findings. So everything has to be taken together for management decisions. There is advanced monitors, I will not go in detail into that. Hypothermia, therapeutic hypothermia, it's not found to have any evidence. Nabish too said that there's no outcome difference between that is early hypothermia, that is within the first 2 to 5 hours of injury, you cool the patient, your outcome is not going to increase. So what you have to do is temperature has to be monitored and fever should be aggressively treated. And for refractory ICP, when all other things doesn't work, you can cool the patient but not to less than 32. Then use bundles, you avoid any constipation, increase in intra-abdominal pressure, treat the comorbidities of the patient. And other important thing is you prognosticate, do family counseling, you end of care of life if it's applicable. And other thing is documentation and legal aspects, brain dead declaration protocols, if it is needed, have to go ahead and declare them brain dead. Outcome, there's a lot of models to predict the outcome. So main things is your how do you manage the patient, the ICP monitoring, anesthesia prophylaxis, osmotherapy, sedation and nutrition. Use the BTF guidelines for the ICP and the CPP threshold. Newer things like atorvastatin, amantadine and cerebrolizin, and surgical management strategies like when you take up the patient for decompression, and there's a lot of importance for rehabilitation. This is something the mantle approach came recently. Then recent advances, atorvastatin, few trials have come in the last 5 years. They found that because antioxidant and anti-inflammatory things are there, it's phase 2 that atorvastatin can be used. Amantadine, which is a dopamine agonist in severe TBI to improve the consciousness and function. And so results are kind of mixed, but short term, some improvement they are seeing. And cerebrolizin is another thing. There's Captain 1 and 2 trials which also show some improvement in the outcome compared to placebo. Other thing is biomarkers. There's alert TBI trial and center TBI trials. There's biomarkers. So one important thing to say is that UCH 1 L1, this is kind of like patient is having mild injury, and you can use it to decide whether you need to go ahead and image the patient or not. That's all. Thank you.
Thank you. So this will be a short topic, ICU outbreaks and management. Actually, even nobody knows how to exactly manage an outbreak, because that's why outbreaks keep happening. So the thing is that we will discuss few prototypes and what all measures you have to take to control the outbreak. So here we go. So outbreaks in ICU, it's a vexing problem. So there is an increase in morbidity, there is an increase in mortality, there is an increase in cost, and occasionally it might require the closure of the ICU. and many time even travelers do come with exotic infection. These things can cause outbreaks. So an outbreak, how do you define an outbreak? It can be defined as an increase in the number of disease cases among patients or staff or above the expected number, which is clustered in time and place. So basically that's an outbreak. It can be a bacterial, viral or fungal outbreak. And if cases like Ebola comes, that again we call it as an outbreak. So when do you suspect an outbreak in an ICU? If there is a similar cases in one unit, and if there are similar cases among similar patients in the ICU, similar cases within a very short span, and if a healthcare worker and a patient is having the same infection, so it might be colonized in the healthcare worker and the patient is carrying the same infection. So all these are reasons by which ICU outbreaks do happen. So how does it happen? It can spread by direct contact or indirect contact. Mostly it is being spread by, most of the infections are spread by hands of healthcare workers, and some patients are colonized, from which this can be transmitted from one person to another. And ICU surfaces are contaminated often, like walls, curtains, mattress, medication pumps, all these things can be contaminated. The water that is used may be contaminated with these so-called organisms like Legionella, Pseudomonas, Acinetobacter. If it is a post-cardiac surgery, and during cardiac surgery they use these heater-cooler devices. So from this device, this bacteria named Mycobacterium chimera might come. And like this, there is a lot, and some of the infection do spread by droplet spread or airborne spread also. So basically there are various modes by which infections come, and all these, as I mentioned, some of them are from the hands of healthcare workers, where, and a lot of healthcare workers are carriers themselves. You swab some healthcare workers, at least some of them will definitely be positive for Staphylococcus aureus, and some of them will be positive for Candida auris if you screen. So some outbreaks like airborne infection, some outbreaks are airborne, some are droplet spread, and some comes from the environment, some come from the AC, like maybe Legionella can come from the air conditioned ducts. So all these can lead to outbreaks. So how do you detect an outbreak, whether an outbreak has happened? So there you have to use this key term, that is a cluster. So a cluster is an unusual grouping of two or more instances of a disease or similar pathogen in a time or space. So if you see a cluster of cases in your ICU, that's a sign of an outbreak. And outbreak also, it is almost similar. So the occurrence of more cases of a disease than expected in a given area will be an outbreak, can be labeled as an outbreak. So many times it is not the doctors that recognize, because we end up treating, because in an ICU, if it is like an open ICU, so occasionally some units will come and treat some case, so that infection might not be noticed by someone else. So it is the lab that calls up and tells that, okay, this, you are having a Klebsiella outbreak in your ICU. So this can come from the lab side also. So how to investigate an outbreak? So basically it is all data. So you have to get a data of what all are the organisms, what all are the common flora in your ICU. If something new is coming, that is definitely an outbreak. So that's the importance of keeping baseline data and reviewing the data every year of your ICU. So always keep a baseline data of your ICU and review the patient records, microbiologic results, and review the hospital databases to see whether, because many times this exotic organism like maybe Stenotrophomonas, Burkholderia, Achromobacter, all these things can come up as outbreaks. So if you see this, you can, maybe one patient might have been in one unit and one patient might be in a ward, but there might be a clustering of these two patients might have come together in the operation theater, where they might have transmitted the disease. So you can see for review the hospital database to see whether something has happened, or you can contact the lab also for the same, and always report to the infection control team in your hospital. Internal reporting is always good, and you have to do a surveillance. Okay, so I'm not going very complex, I will simplify the things in my coming slides. So there is something called as a pseudo outbreak also. So an outbreak, so in outbreak there will be a clinical infection, and there is a disease transmission also. But in an pseudo outbreak, it happens that suppose there is a lab error. Okay, the lab is detecting more, or suppose the lab has changed the testing strategy, and if the sensitivity is not good, that might detect more infections, and that's why the lab based outbreaks come. Sample contamination can take place in the lab itself. Okay, it can take place from the laboratory worker, and they will tell, okay, all these samples are growing Candida auris from your ICU. So that is not actually an outbreak. And if there is only an increase in the positive cultures, but all your patients are fine, then it is mostly a pseudo outbreak. It is not a proper outbreak. But if the patients are sick, it is always an outbreak. So for an outbreak, definite investigation and interventions are required, whereas for pseudo outbreak, only the correction of the lab error is required most of the time. So coming to few organisms and how the outbreaks used to come. So as there have been stories of Acinetobacter outbreaks coming from contaminated bronchoscopes that have been used. Candida auris, there is a article, there was this so-called article in the NEJM journal where they found a big Candida auris outbreak, and eventually it was from the axillary temperature probes. That was the place from where it was isolated. So this Mycobacterium chimera is becoming more common, especially in cardiac surgeries. They come from the heater cooler devices that are being used in the surgeries. Clostridium difficile, I have already discussed. It mostly comes from hands of healthcare workers itself. And Klebsiella, if you see for the sinks, because Klebsiella is somewhere related to water. So always if you have an outbreak of Klebsiella, you check all the water points in your ICU. You check the taps, all this region, you have to and do the decontamination. Burkholderia, this kind of stuff come from ultrasound gels and all. So if Burkholderia outbreak is there, you can, well, I will explain these things in detail. So these are some things that could be checked when you have outbreaks. And Burkholderia has come from pre-contaminated vials of drugs also. So some cardiac patient got Burkholderia where I was working, and when they checked, all the patient had received Lasix, and when this Lasix from this so-called particular company was tested, that was positive for Burkholderia. So it was a pre-contamination of the vials. So there are a lot of stories if you go about. I am not going into the details. So how do we prevent? And we will split up some infection and go about dealing with it. So always you ensure your infection prevention and control. Hand hygiene is the most important thing. And if an outbreak is detected, always use barrier measures. So try to isolate the patient. If your isolation is not possible, you cohort the patient. Okay. And environmental cleaning is important, and reinforce the infection control practices and do skin decontamination with chlorhexidine. Practice good antimicrobial stewardship. Nowadays, if anybody is planning to build a good ICU, if you're building an ICU, always practice this thing, antibiotic stewardship, because the thing is that whichever new patients comes, if you are not using something like a meropenem, the probability of getting a meropenem resistant organism in your ICU will be lesser. Of course, some cases do come referred, but if more cases, this especially if you are building a transplant ICU, okay, because in transplant ICUs, if you are building, if you start your regime with something like maybe cefepime and enmetazobactam, so that is a meropenem sparing but treating ESBL thing. So if you go like this, maybe in later days you can preserve meropenem in this. So in the other ICUs I am not telling, because patient might have run 2-3 hospital before landing up in a tertiary care ICU, so it will be difficult, but it can very well be done if you are setting up a transplant ICU. So the most notorious organism nowadays is Candida auris, which causes lot of outbreak. Why it causes outbreak? It is a propensity to contaminate the hospital environment, and it remains in the hospital environment on surfaces for very long time, and even the colonized patient also shed these fungi, Candida auris. So if the hand hygiene is not proper, and if you are failing to remove the gloves after from moving from one patient to the another, and you are holding on to the rails of the next patient, it will contaminate that region also. So how do you screen for Candida auris? So you do a swab culture from the nose, axilla, groin. If there are any wounds, you do it from the wounds, and do urine culture also. And this swabbing has to be done thrice weekly. If you are doing a screening process of all the patients in your ICU, do it 3 times weekly, so that you can detect whether a Candida auris outbreak has happened. So it is important, as I mentioned, this fungus stays on the skin for a very long time, and it lives on surface also for a very long time, and it can be spread to others. It lives on surface and it can be spread to others. So how do you control a Candida auris? How do you prevent and how do you control? So if Candida auris is detected, if at all possible, keep the patient in a separate room. If you have a separate cubicle in your ICU, keep the patient there and ensure that hand hygiene is practiced. It is always better that Candida auris, all the Candida auris patient, positive patient can be nursed by one nurse. Okay, and please try to not put this nurse in the for nursing the other patient. The problem is that suppose somebody is colonized, this patient might not have the infection, but another one who has come to your ICU with some other illness, they might get a bloodstream infection with Candida, and the prognosis is really poor. So you will have to clean and disinfect the patient care environment. It should be daily and terminal cleaning, and inter-facility transfer communication. So from one ICU to the other ICU, from one hospital to other. So all these things should be taken care of in a very meticulous manner to prevent Candida auris spread in the hospital. And whoever has come to contact, if you are suspecting an outbreak, you should screen all those people who are involved, including the healthcare workers. So these kind of surveillance can detect who is the person who is contaminating with Candida auris, and you can keep them isolated. The measures are not that bad. You can do a chlorhexidine wash, chlorhexidine bath, chlorhexidine soaps. So these things will remove Candida auris. But the thing is, you have to identify who is infected. So what can be done is, if somebody has Candida auris, the patient can be wiped with a chlorhexidine, wiped with chlorhexidine daily. And mind you, the wiping should involve the axilla and groin region always, because that's the region from which a lot of shedding happens. And hand hygiene should be reinforced, and one nurse, one patient. Infection control measures, use appropriate antibiotic, but all the colonized patient need not be treated, because fluconazole does not work. You will have to go for echinocandins. So no need to treat all the patient, only the infected patient, those who have bloodstream infection, or those for those who are showing signs of urinary infection. So those are the people who needs to be treated and eliminate the contaminated products. So this is about Candida auris. Nowadays it is upcoming and it is becoming a terror, because many times it does get treated. You give something like a caspofungin or andulofungin, the blood culture do get negative. But if you take the worldwide statistics, whoever has infected with Candida auris, the mortality is much higher. Okay, so that's why this needs to be avoided. Coming to the next thing, next is MRSA. MRSA outbreaks. MRSA mostly comes from lines, in patients on lines, and it spread again. Healthcare workers can be carriers. So use of vascular catheters, endotracheal tubes, and prolonged ICU stay, colonized healthcare workers, high patient turnover between units. So all these are reasons for acquiring MRSA. And how do you manage MRSA? Any patient, if a patient is identified to have MRSA, always change all the lines, especially the center lines. And it would be a good practice if you could screen the healthcare workers, especially in places like ICUs, transplant units, etc. Whoever is being posted, you can screen them for MRSA. If they are MRSA positive, you can ask them to take nasal mupirocin 5 days continuously, and the repeat screening is might come positive again. If you can do a repeat screening, it is not like, but most of the time this might run for a period of 3 months. That's what is usually seen. And do hand hygiene. and lesson shifting of this patient colonized with MRSA for different procedures, because MRSA is a notorious organism just like Candida auris. Once it gets in your body, it is very difficult to eradicate that. So it can go and seed in the spine, go and seed in the heart. It causes a lot of problem and lessen the number of staff who are coming to contact with the MRSA affected patient. So this is about MRSA. So the most notorious in hospital nowadays are, one is MRSA and next one is Candida auris. These are the most difficult to eliminate. Of course, I will come to the gram negative. So the next one is carbapenem resistant Klebsiella. So Klebsiella, it can colonize the gastrointestinal tract, and actually especially this happens in patients with liver diseases, chronic liver disease. What happens is, if somebody's gut is already colonized, so there can be gut translocation, especially in CLD patient, and that can cause bacteremia with carbapenem resistant Klebsiella. We cannot do anything about that. Those patients just need treatment. But in an ICU, such the Klebsiella can be seen colonized in this wherever there is relation to water. So hand washing sinks is very common area of contamination with Klebsiella. Surfaces of trolleys also are often contaminated with Klebsiella, and so these are the areas that needs disinfection if you have a outbreak of Klebsiella in your ICU. So how to control? All the rules remain same. Patient isolation and cohorting and hand hygiene remain same, and environment cleaning and disinfection, and focus on high-touch surface, especially these are the areas: hand washing sinks and trolley surfaces. These are some places where you should take extra care in a Klebsiella outbreak. And this, whether you should swab all the patient for Klebsiella, it is very doubtful. Okay, because if you do rectal swab, this is being done in those doing bone marrow transplant and all, they do a rectal swab. Lot of them come positive for carbapenem resistant Klebsiella, but whether you end up treating them or not, it is purely upon the clinician. So it might not be a right practice, but you can change these door buttons and all. Often it is like it should be a no contact door opening, so that will be the best. And so that's how you could control Klebsiella outbreaks. Other gram negative Pseudomonas, again Pseudomonas is almost always related to water. So contaminated water outlets in the ICU, like wash hand basins, sinks, pipes, ventilator flow sensors. So these are some regions where Pseudomonas are most commonly located. Of course, it can occur in other regions like temperature probes, crash cart, bed rails, etc. But if you have a Pseudomonas outbreak, most often it will be located somewhere near your wash basins. Okay, so that's how you identify the prime location of a Pseudomonas outbreak, and then you cohort the patient, and mostly the patient the outbreak can be controlled. So because Pseudomonas has a risk of biofilm formation in wet surfaces, so that is why the Pseudomonas keep existing over there, and so that's why a thorough wiping and environment cleaning of these so-called areas will help to eliminate Pseudomonas outbreaks. And Acinetobacter, it is a notorious organism nowadays, but actually the exact site mostly it is difficult to localize. So you will have to look everywhere: bed rails, mattress, ventilator tubing, water points. All these are areas of Acinetobacter outbreaks. It is not like Pseudomonas. You cannot pinpoint an exact point in Acinetobacter outbreak. That's why it is keeping on coming. But I would say that Acinetobacter is actually a fragile organism. You just wipe it and it goes. It is not bad like Candida auris or C. difficile. If you clean properly, Acinetobacter goes always. Okay. So another one, Burkholderia. Burkholderia is usually not a contaminant. That's why you are not getting lot of cases of Burkholderia in your ICUs. Burkholderia, how it comes, as I told, you see for contaminated medical solution. If more than one patient in your ICU is having Burkholderia, if there are one thing is cystic fibrosis patient can have that. Other than that, if it is there, you always see for this IV solution, whether these patients are getting common IV drugs, like it can be an anesthetic drug, it can be something like furosemide, it can be an antibiotic. So pre-contamination is one possibility by which Burkholderia outbreak comes. And again, these skin care products and bath products in the ICU, some kind of soaps and all, are pre-contaminated with Burkholderia. Ultrasound gels, which you use for almost all your patients, that can be contaminated with Burkholderia. So if you are getting the outbreak with this particular organism, you check this. It is not like Pseudomonas. It is a different way of checking. Okay. So now some non-TB mycobacterium also do contaminate nowadays. So contaminated mycobacterium chelone. So it is like if this thing comes again, you see for the piping system of the hospital. If more patients are having, there is some problem with the piping, or it can contaminate this kind of instrument like bronchoscope and laparoscopic instrument. So that's where this comes. It is usually does not come from all the bed railings and all, because non-TB mycobacteria are actually ubiquitous. So if it enters to some patient, so these are the common region where you use laparoscope or bronchoscope, which you make to inject this bacteria. So that is how outbreaks with mycobacterium chelone occurs. Okay. So few more things. Suppose somebody in the ICU is having a chickenpox. There is a very high propensity of an outbreak. Even a staff is having chickenpox. So if patient is there, patient has to be isolated. There is no doubt about that. It has an airborne spread. You have a negative pressure room in your hospital, you just push this patient over there, and limit caregiver access to this, because many times the caregivers might go out and they will spread the infection. So if there are immunocompromised patient in your ICU and they who have been exposed to them, you can give prophylactic acyclovir. There is nothing wrong with that. Acyclovir, if you give as a prophylaxis, it is said that it is to be started after day 7 of exposure. From day 7 to day 14, that is the time when you should give acyclovir. It is not like the next bed patient is having chickenpox. You need not start the acyclovir the very next day. You can wait 7 days and then only start it. But once started, you give it for 7 days. That's how it goes. And healthcare workers are for healthcare workers who, but nowadays most hospitals are checking varicella IgG by the time of employment. If not checking, and if the healthcare worker has not got a history of chickenpox, a vaccine can be given immediately. So chickenpox vaccine has this advantage of acting as a post-exposure prophylaxis. It is said that within 5 days it has effect, but at the earliest after exposure you give vaccine, it has a protective role. And staff work restriction, this might not go well with any hospital management, but actually that is something that can be practiced. And however, the patient should not be transported between units. So even for an X-ray, it is not advisable to shift the patient. PPE for varicella zoster cases is always N95 mask and do infection control measures. So this about varicella. So some things are really peculiar. You go in for negative pressure rooms. If it is influenza, I am not talking COVID. All of you are fed up with COVID, so I am not talking COVID. I will deal influenza. So if the rooms are limited, do patient cohorting, because influenza comes in large numbers actually. So do patient cohorting, and it does not need N95 mask. You can wear just surgical masks only. And antiviral treatment. So for the confirmed cases, you give antiviral. And exposed healthcare workers, it is better, especially if you are in a high risk unit, maybe like a transplant unit, it is better that the exposed people also takes prophylactic medicine, 75 milligram once daily oseltamivir. Annual influenza vaccine, but the problem with influenza, it is advisable to take influenza vaccine. It is a good vaccine, but I would say that the protection rate will be somewhere near 60 to 70%, not more than that. So even if you are vaccinated, it does not mean that you are always protected against influenza. And if aerosol generating procedures are performed, use negative pressure room, and active surveillance for new cases are to be done. So regarding PPE, always you wear the appropriate PPE to save yourself if you want to save your patient. Okay. So now just the last thing, nowadays the infection control measures have improved a lot. So if you really want to know from where your infection has come, or who all is having the exact infection, there is this which can be done, that is whole genome sequencing, which can be used as surveillance. Nowadays a lot of outbreaks are being detected with help of sequencing, surveillance using sequencing. So it can tell that suppose 3 patients are having carbapenem resistant Klebsiella. Okay, so as a clinician you tell that okay, my ICU is having an outbreak, but you send for sequencing. If all the strains are different, it is not actually an outbreak. Okay, so this might have come from different sources. This patient might have got it from different people. So this can even refute the presence of outbreaks. It can confirm also. And but the problem is that it is difficult to find the route of transmission. It can just tell that okay, this outbreak is there and so patient is having outbreak from this. Transmission route, again you will have to go and screen, just like what our healthcare workers do when a Nipah comes. They will create a route map. You have to create route maps and you have to take swabs from various areas and you can try which area matches with your sequence. And maybe if AI can be incorporated, machine learning can be incorporated, that might in the future solve a lot of problems. So based on syndrome, what will be easier will be you can do just syndromic surveillance. So if patients in the same unit are having a cough, okay, that might be an indication that you should send influenza testing for all of them. So that's how you detect outbreak. Of course, laboratories can call you and they can tell you that outbreaks are happening. And so only thing is, as an intensivist, you should maintain a high suspicion, because an outbreak is there. Actually, that is outside the plans, outside your routine treatment plan. Okay, so if a patient has come in with a urosepsis and there is an outbreak of influenza running, now this patient is going in for ARDS and you are treating an entirely different issue. So always you should be on the watch out for outbreaks. There are newer technologies like biosensors and robots equipped with biosensors. All these things, air sampling measures, all these can in the future can solve a lot of problems of detecting outbreaks. And whole genome surveillance definitely can detect outbreaks even if there are only 2 patients with the same organism. It can tell that an outbreak will happen. Maybe at later date when the insurance takes up everything, this might create a lot of problems also, because if everybody is having the same strain, insurance companies might deny that this has come from your hospital, we are not bound to give that. So these things might happen in the future. As of now, we are safe. Okay, thank you.